Okay. Good morning, and thank you to the ACIA for inviting me to speak here today. My name is Heather Smith. I'm a medical student at the University of Utah, and today I will be presenting the results on a multinational database study on the risk of complications after pediatric cochlear implantation. Here are the disclosures for my team. I personally don't have any conflicts of interest to report. First, for some background, meningitis is a rare but life-threatening complication that has occurred after cochlear implantation. It was first described in 2002 and was found to be around 30 times the risk of the general population and was found to be associated with the use of a positioner device in the cochlear implant, which has subsequently been recalled from the market. The risk of meningitis after cochlear implant is thought to decrease rapidly after the early perioperative period, and a high level of vigilance is recommended to diagnose and treat these cases early. Other complications after cochlear implantation include things such as facial weakness, dizziness, implant complications, and CSF leak. And the incidence of these have not been thoroughly described in large multinational cohorts of pediatric patients. The objectives of this study were first to determine the risk of meningitis and other complications after CI surgery in a pediatric population, and secondly, to quantify these risks as compared with children who did not receive a cochlear implant. In order to do this, we used the TriNetX Research Network. TriNetX is a global health research platform that provides access to de-identified health information from over 99 million patients across 84 healthcare organizations in 4 countries at the time of this analysis, although that number is constantly growing. Most of the data in the study was from after 2007, and the mean follow-up time in our patient population was 5 years. We queried the TriNetX Research Network using ICD-10 and CPT codes to build 3 patient cohorts. The first CI cohort consisted of patients who underwent cochlear implant prior to the age of 18. We also created a comparison non-CI cohort of patients who never underwent CI, as well as a non-CI cohort of patients who also had sensorineural hearing loss. We did this to help control for underlying sensorineural hearing loss, which may be an independent risk factor for some of the conditions that we studied. And then finally, in order to ensure that age and sex distribution was similar between the cohorts, we used the built-in propensity score matching algorithm within the TriNetX database, which created a one-to-one matching between cohorts for age and sex. With the index event set as cochlear implant surgery in the CI cohort and any patient visit in the non-CI cohorts, patient records were examined for the incidence of these following ICD-10 codes in their records at various time frames after their surgery. All statistical analysis, including summary of demographic information, as well as calculation of absolute and relative risks, were performed within the TriNetX platform. After matching for age and sex, both the CI and the non-CI cohorts consisted of 4,770 patients each, with a mean age of 5.1 years, and was 50-50 male and female. However, there were some slight racial differences between the groups. Here are some of the risks of early complications within 1 week of cochlear implant surgery within the CI cohort. The most common of these was complication of the internal prosthesis or implant, which included things like displacement, mechanical breakdown, or inflammatory reactions. This occurred in 1.72% of the cohort within 1 week of surgery. Other complications in the first week included intra and post-operative complications of the ear, dizziness, CSF leak, facial weakness, and labyrinthitis, each occurring in less than 1% of the population. When assessing the risk of meningitis in particular, we found that the CI cohort had 1.11% risk of meningitis within the first 6 weeks after surgery. The risk within the first year was 1.55%, and then the risk of meningitis occurring 1 year or more after surgery was 1.09%. Overall, the risk of meningitis after cochlear implantation was 2.11%. Additionally, anytime after CI surgery, the risk of labyrinthitis was 0.63%, the risk of facial weakness was 0.69%, and the risk of dizziness was 3.76%. When we compared the risks in the CI cohort compared to the risk in the non-CI cohort, we found that the CI cohort was at more than 3 times the risk of dizziness and more than twice the risk of labyrinthitis and facial weakness. The CI cohort had 8 times the risk of meningitis as compared to children without a cochlear implant. We also compared the risk in the CI cohort with the non-CI cohort with sensorineural hearing loss, and here we found that there was no difference between the risk of dizziness and facial weakness between the 2 cohorts. However, the CI cohort was still at an elevated risk of almost 3 times the risk of labyrinthitis and meningitis as compared with children with hearing loss who did not undergo cochlear implant. A couple points of discussion I'd like to bring up. The first study of meningitis after pediatric cochlear implantation from 2002 reported an incidence of more than 30 times that of the general population, whereas our study found a risk of 8 times. Since most of our data are from well after the positioner device was discontinued, this study provides an updated analysis of the meningitis risk using contemporary devices and surgical techniques. So while the risk was maybe lower than that of the initial reports, it still is quite elevated at 8 times that of the general population. Additionally, the American Academy of Pediatrics recommends that episodes of acute otitis media be treated aggressively when it occurs within 2 months after cochlear implant surgery. As a result of the study suggests that the meningitis risk remains elevated even a year or more after cochlear implant, this may inform future changes to recommendations, for example, to treat otitis media more aggressively even after the 2-month postoperative window. Of course, the retrospective design, as with all observational studies, mean that we can only determine an association rather than a causation. There are also several limitations inherent to the use of the Trinetics database. If a patient transfers care from a Trinetics reporting organization to an organization that does not report to Trinetics, their information may be lost to follow-up within the database, which can lead to underrepresentation of the number of patients experiencing certain outcomes. However, we estimate this would not significantly alter our findings as the mean follow-up in this population was 5 years. We are further limited by reliance on billing codes in a patient's record, which can be subject to error, and this also means that we do not have access to granular details regarding audiometric measures or symptom severity and improvement. In conclusion, the risk of meningitis after cochlear implantation in children was 1.55% within the first year and 2.11% anytime after surgery. Children who underwent cochlear implant were at a higher risk of meningitis, dizziness, facial weakness, and labyrinthitis than children without a cochlear implant. However, compared to children without a cochlear implant who also had hearing loss, children with a cochlear implant were not at an elevated risk of facial weakness or dizziness. This suggests that dizziness and facial weakness may be associated with an underlying etiology related to hearing loss, with no elevated risk from undergoing the surgery itself. Children undergoing cochlear implant did remain at an elevated risk of meningitis and labyrinthitis compared to those without cochlear implant, regardless of their hearing status. Here are my references. Okay, thank you very much.
Excellent, and now we'll invite Erica Gagnon.
Good morning, my name is Erica Gagnon, and today we're going to talk about factors influencing pediatric cochlear implant device use. Here are my disclosures, and I would like to thank the team at UNC. 5 years ago, my colleague, Dr. Lisa Park, introduced the hearing hours percentage as a novel metric for cochlear implant device use. The HHP contextualizes cochlear implant device use, or hearing time, to age-matched normal hearing peers. If these normal hearing peers are awake, then they are hearing. This also accounts for the difference in sleep-wake time as a child ages. We know that babies are going to nap and have earlier bedtimes, and so we want to account for this difference, knowing that their wear time or access to sound will increase with age. So how are we calculating the hearing hours percentage? We took the inverse of a sleep meta-analysis. If we know how long you're asleep, we can calculate how long you are awake. That's in the table on the right there. We're then taking the objective wear time data from the CI software and making that a percentage. To give some context, 8 hours of device use is often a benchmark in the literature. So what does that look like with the hearing hours percentage? In a 9-month-old, that's a 71% hearing hours percentage. Moving to school age in a 6-year-old, that's a 57% hearing hours percentage. And then moving to our teenagers, that drops down to a 52% hearing hours percentage, or just over half of their day. So for our questions, the hearing hours percentage contextualizes a CI user's access to sound relative to A, their age-matched peers, B, 8 hours, or C, 10 hours. The answer is age-matched peers. So if we're looking at factors that impact cochlear implant device use, what are the barriers? Wiseman and Werner-Sis found that chronologic age, or the youngest recipients, have reduced wear time. They also found that intellectual and developmental disabilities led to reduced device use. Public insurance, or Medicaid, was found by Awad and Wiseman and Werner-Sis to also have reduced device use. Iswar et al. Found that the earliest years of a CI user's device use are reduced relative to later in their device usage. And then we've sadly found that the years of the COVID pandemic have had a negative impact on device use. So our study was an exploratory study to investigate the implications with respect to the hearing hours percentage on pediatric CI users. We looked at race and ethnicity, listening type or configuration, type of insurance, presence of a developmental delay, age at the surgery, age at the test interval, and then the year of the data collection. This was a retrospective query into our database. Inclusion criteria was quite broad. You just had to be under 18 at the time of the data acquisition, and we had to have data logging information at the visit. For our bilateral CI recipients, sometimes there's a discrepancy between ears, and so we took the ear that had the highest hearing hours percentage. We also have users that sleep in their cochlear implant, and so because this isn't reflecting access to language, we normalized anything greater than 100% back to 100%. Here's some details about our subjects. We had 5,106 data points from 958 subjects. The mean hearing hours percentage of the group was 64.2%. The mean age of surgery was 2.6 years, and the mean length of device use was 5.3 years. Here's some more information on just the etiology of our subjects. And now on to the results. The first one is looking at comorbidities. So the referent is on the left in the gray with the box outlining it. We found that presence of autism spectrum disorder or an intellectual disability resulted in significantly less hearing hours percentage than those without. Moving on to insurance. Private insurance is, again, the referent all the way on the left in the yellow. We found that children with Medicaid had a significantly reduced hearing hours percentage relative to private insurance, and no difference with those with military insurance via TRICARE or who were self-pay or had no insurance. This next one looks at listening configuration and then year of data collection. So those who were implanted simultaneously, had sequential implantation, are bimodal recipients, or unilateral hearing loss with a cochlear implant. For all of them, 2019 or before the pandemic is the referent in that kind of salmon color. We see for all of these listening configurations, there was significantly reduced device use during the pandemic. We found for those that were sequentially implanted and those bimodal recipients that by 2023, device use had resumed back to baseline. However, for those that were simultaneous bilateral recipients or unilateral hearing loss with a cochlear implant, it has not resumed back to baseline. This graph is really busy. We've got the age at the test interval on the x-axis and the hearing hours percentage on the y-axis. What we see is as the child ages, their hearing hours percentage also increases. This is nice to see because the HHP is factoring that sleep-wake time. So not only are we seeing an increase in hours of device use, but percentage of device use, which is really nice. Also something to keep in mind, though, for those youngest recipients that they might need some extra counseling and help with retention, because we know that's a challenge at these younger ages. For this next one, the age of the child at surgery, the younger the child was implanted, the greater their wear time. And then the older the child was, we saw a reduction in device use via the HHP, which really reinforces the need for timely intervention with cochlear implantation for best outcomes. So question number 2, children with Medicaid had the same, significantly lower, or significantly higher hearing hours percentage than those with private insurance. The answer is B, significantly lower. And then the next question, during the COVID pandemic, pediatric cochlear implant device use remained stable, increased, or decreased? The answer is decreased. So in conclusion, the mean hearing hours percentage of our cohort was only 64.2%. Previous literature has shown that an 80% HHP is the minimum wear time recommendation, so we're still a bit off from that. We found that children with an intellectual disability or autism did have reduced wear time. We found that Medicaid status also related to a lower wear time. We did not find an impact of race or ethnicity on wear time. We found that age of the study revealed increased hearing hours percentage, and then that the COVID pandemic did impact device use with the greatest impact on those with unilateral hearing loss, and that for those and the bilateral simultaneous recipients, it has not recovered to pre-pandemic levels. Here are my references.
Now we'll invite Catherine Tonkovich up.
Good morning. Thanks for sticking it out with us on Saturday. I'm Katie Tonkovich. I'm one of the pediatric audiologists at Primary Children's Hospital in Salt Lake City. I'd like to thank the conference committee for the opportunity to discuss our findings from our retrospective study involving the impact of the COVID-19 pandemic on cochlear implant device use and habilitation in our pediatric recipients. I'd like to thank my co-authors and collaborators. This presentation would not be possible without their help and their data analysis. Note that we have some disclosures as well. I'm a clinical audiologist, so I don't have a lot of time for research, so this is not something I could do on my own. Our team at Primary Children's Hospital consists of 20 audiologists. We have 2 audiology aides and 1 manager, and we have 2 inpatient hospitals and 4 outpatient clinics. And because of our location, we serve a lot of patients from neighboring states, including Montana, Wyoming, Idaho, and Nevada. And then we have a multidisciplinary cochlear implant team that meets monthly to discuss complex cases, and we're very fortunate to have a group of experts on our team, including speech-language pathologists, early interventionists, educational audiologists, and our colleagues from Utah State University, as well as our surgeons. And Primary Children's recently celebrated their 100th birthday. We know that cochlear implant wear time directly affects outcomes involving speech and language development, and we just heard a lot about that average hour wear time. Wiseman et al. Found a significant correlation between daily device use and early auditory skills, and we know that the overall hearing hour percentage significantly predicts receptive language scores. That was very fortuitous. And the age at which children reach their full-time device use is a better predictor of language outcomes than their age at surgery. We also know the COVID-19 pandemic disrupted routine habilitation efforts and presented a lot of challenges for device use. And I'm sure I don't need to tell you that COVID-19 caused major disruptions in services. Like many clinics around the country, our offices closed between March 2020 and June 2020, with school programs also closing for the remainder of the calendar year. So we had a major disruption. Additionally, elective procedures like cochlear implant procedures were paused to free up hospital space and beds so that efforts could go toward critical care and meet those demands. So we wanted to look at our device use pre-COVID and post-COVID between the years of 2018 and 2023. And we wanted to evaluate the average data logging for those patients and then try to discuss some strategies to mitigate any negative effects. For our method, we conducted a comprehensive chart review and found 186 pediatric patients who received cochlear implants between 2018 and 2023. So we created a database, and then we were able to see how it broke down between when they received their cochlear implant, which manufacturer they had, and their etiology, and that we're hoping that will help us collect more data in the future. And you can see how the manufacturer selection breaks down. We have the majority with cochlear, and then advanced mechanics and metal, sort of splitting the difference there. And then for data collection, we analyzed the average data logging that was reported in routine visits when children were coming for their programming appointments. For the statistical analysis, we performed ANOVA to assess the data and identify any significant patterns. This slide just shows the distribution of cochlear implant surgeries by year. So you can see we had more cochlear implant surgeries in 2019, and then of course, it took a dive in 2020 and 2021. And then it was kind of starting to come back up again. We did find a significant effect for the year our patients received their cochlear implant and how it correlated with average device wear time. So for those subjects who were implanted before COVID-19, our average daily device use was around 10 hours a day, which is still not 12 to 14 hours a day, depending on how old you are. And then conversely, subjects that were implanted afterwards had only a mean daily device use of 5 to 6 hours a day. So that was quite sobering, and it shows us that we have a lot of work to do to catch up. And then we did not find a significant difference between the children who received cochlear implants during the pandemic in 2020 or after. And so we still haven't caught up to those pre-COVID data logging hours. So then we also wanted to look at our SSD population because we know that there's some challenges for those patients as far as increasing their wear time. And so we did find that their wear time was slightly less than our bilateral patients, but there wasn't a statistically significant difference for them. And there were 28 SSD patients. So in conclusion, we know the COVID-19 pandemic significantly influenced cochlear implant device wear time. And for a minute, I was wondering if that was a Utah problem, but it sounds like it's not just us. I would be curious to know what other centers are seeing. And I put a screenshot of one of my patients up there. This patient is actually a single-sided deaf patient. And it's just a reminder that while these findings were kind of depressing, I want to celebrate some of the little victories and the little wins that we have. This was a patient who started out strong with her device when she was 7 or 8 years old, then hit those preteen years and stopped wearing it consistently during COVID. But now she's back up to 12 hours a day. So that took a lot of counseling, a lot of coaching, a lot of just kind of repeating the same things about the importance of wear time and stimulating those auditory pathways. So we know that unfortunately the challenges from the COVID-19 pandemic persist and require improvements in our habilitation process. We want to know what we can do to get back to those pre-COVID data logging levels. So to address those, I think we need to take a look at our counseling strategies. My personal counseling strategy, I don't think it's really changed much prior to COVID, but for whatever reason, this message might still not be getting across. I think we need consistent messaging between agencies. We share a lot of patients with our early intervention agencies, and I'm not sure that our message is consistent. And then we always ask what additional barriers families are having. I try not to be good cop, bad cop when parents come in. I just ask, what challenges are you having as far as reaching this goal that we know is so important? And sometimes it's retention. Sometimes it's just helping educate other caregivers, like daycare providers, who might be afraid to put the devices on because they don't want them to get lost. So other things like that I think are going to be really important to identify what those barriers are. And then we're hoping to take another deep dive into our data. This was a very general question we had. We just looked at average wear time pre-COVID, average wear time post-COVID, and the data is actually pretty messy. So what we want to do is kind of do a deeper dive, look at demographics, look at etiology, what are the other factors that might be going into this, what is the communication modality, what does the school program and support look like. So those are all really important things that now that we've identified the problem, we want to really investigate. Here are my references, and thank you very much.
Excellent, and now we'll hear from Jay Maturi.
Nice. Hello, everyone. Thank you so much for being here. My name is Jay Maturi. I'm a third-year medical student at Johns Hopkins, and today I'll be presenting my team's work, a systematic review and meta-analysis examining outcomes of cochlear implantation in children with bilateral cochlear nerve deficiency. I think. I have no disclosures. So cochlear nerve deficiency is defined as an absent or small cochlear nerve as it runs through the internal auditory canal. On the left is a normal parasagittal T2 weighted MRI image of the internal auditory canal, or IAC. On the right, we can visualize an absent cochlear nerve in the anterior-inferior portion of the IAC. Patients with cochlear nerve hypoplasia will have a thin cochlear nerve, generally defined as a nerve that's smaller than that of the facial nerve. Thus, therapeutic options to restore hearing in this population are critical for long-term speech and development. So, cochlear implantation serves as this therapeutic option for many patients with sensorineural hearing loss. Because cochlear implants rely on the cochlear nerve to transmit this signal, cochlear implants were previously contraindicated in this population. However, growing evidence from case reports in small series suggests that there may be a role for cochlear implants in restoring hearing in C&D patients, but the outcomes are variable. Thus, we developed a systematic review and meta-analysis to aggregate data on this patient population. Maybe. Sorry.
That's okay. Not to say I have magic fingers.
Yeah, no, I trust you. Oh. Great. So, the objectives of this analysis were to characterize outcomes of cochlear implantation in pediatric patients with bilateral CND, to identify factors associated with improved outcomes. So do patients with cochlear nerve hypoplasia do significantly better than those with aplasia? Do patients with inner ear malformations, either cochlear or vestibular, do they do significantly worse? And do patients with syndromes perform significantly worse than those without syndromes? So the database search strategy included studies that involved pediatric patients, cochlear implantation, and bilateral cochlear nerve deficiency across PubMed, Embase, and Web of Science. Patient characteristics, workup and surgical details, as well as their outcomes were extracted from each study. So we had 314 studies that met the initial search criteria, 104 studies were assessed for full text review, and then 40 studies were included in our final review. So the biggest challenge in this analysis was that all these studies were conducted around the world, and they used many different metrics to evaluate hearing and speech outcomes. So to address this heterogeneity, we utilized the auditory perception level scale, as developed by Young and others in 2012. So it defines hearing outcomes into one of 4 categories. Level 1 is non-stimulation or minimal detection following their implant. Level 2 is some perceived improved detection. Level 3 is obtaining closed set speech perception, and level 4 is open set speech perception. So some of those common audiometric metrics, like the categories of auditory perception or the speech intelligibility rating system, were converted into APL scores. And on the right is kind of our comprehensive list of scores that were used in these studies and how we converted them to levels 1, 2, 3, or 4. So our overall cohort consisted of 339 patients with bilateral C&D with outcomes that were translatable to our APL scoring system. About 185 patients had bilateral cochlear nerve aplasia, 57 patients had bilateral cochlear nerve hypoplasia, and 25% had mixed hypoplasia-aplasia, of those that reported the nerve status. And most patients underwent a unilateral implantation. We used Cochrane-Armitage tests to analyze significant differences in the distribution of APL scores across each demographic or clinical factor. And an interaction variable was used to assess associations between demographic and clinical factors and nerve status, and analyses were stratified when appropriate. So here are the main results from our analysis. We found that among 339 patients, 31%, or 105, obtained open set speech following their implant. 22% achieved closed set speech, 28% had some improved detection, and about 1/5 of the patients, 19%, had no perceivable benefit from their cochlear implant. We can now stratify these results by different demographic and clinical factors. And first is nerve status. So when we stratified by nerve status, we found that patients with cochlear nerve hypoplasia performed significantly better than those with cochlear nerve aplasia. In fact, 44% of those with cochlear nerve hypoplasia achieved open set speech, relative to 33% with cochlear nerve aplasia. So the important role that nerve status plays in prognosis highlights the need for high-quality imaging of the IAC for accurate diagnosis. So MRI using direct parasagittal images perpendicular to the long axis of the internal auditory canal is best to assess the anatomical presence and size of the cochlear nerve. Reconstructed parasagittal images often blur within the confines of the bony environment, like the IAC, which can limit its sensitivity in definitively identifying C&D. So of the 14 studies that were included that noted the type of MRI used, 6 of them used direct parasagittal imaging, and 8 of them used reconstructed parasagittal imaging. So utilizing direct parasagittal imaging may be critical in predicting outcomes and setting expectations for children with C&D undergoing cochlear implants. So syndromes present a multifactorial challenge to hearing and speech outcomes due to potential concomitant neurodevelopmental delays that can impede learning and speech development. So overall, 20 to 40% of all sensory neural and hearing loss occurs in patients with syndromic etiologies, and several syndromes are associated with cochlear nerve deficiency, with the most common being CHARGE syndrome. So we found in our analysis that patients with syndromes perform significantly worse than those without syndromes, with 38% of those with syndromes achieving no discernible benefit, non-stimulation or minimal detection, relative to those without syndromes. There was a significant interaction between age and nerve status, so analyses were stratified for this population. Among patients with cochlear nerve hypoplasia, there is no significant difference in outcomes between those older than 2 years and those younger than 2 years. However, among patients with cochlear nerve aplasia, those older than 2 achieved significantly better outcomes than those that were younger than 2. We believe one reason for this is due to the short follow-up window for many of the patients in the reported studies. So those under age 2 may not have had adequate time to experience the full benefit of their cochlear implant and develop that closed and open set speech. So we still believe that earlier implantation is critical for high-quality outcomes of their CI. Additional meta-analysis results, there were no significant differences in APL score between those with or without cochlear malformations or vestibular malformations, which is a little surprising to us. And quality of life outcomes have always been underreported in this population, and traditional hearing and speech outcomes may not reflect the full benefit of the CI. So few studies included data on quality of life, modes of communication, or school setting. Of those that did report that data, 20% of patients ended up in a mainstream school setting. In particular, quality of life measures are helpful in understanding the benefit of CI in a more complex patient population that may not achieve the traditional outcome targets, including open set speech and expressive language, but still benefit from that increased environmental awareness. One qualitative study by Wieldy and others found that patients with syndromes had universal benefit from their CI, even if they didn't meet the same audiometric goals as their peers without syndromes. So here are the key takeaways I'd love for you all to take away from this analysis. Cochlear implantation is a viable therapeutic option for patients with cochlear nerve deficiency. Outcomes were heterogeneous, though, and 1/5 of patients achieved minimal detection or non-stimulation with their implant. Patients with cochlear nerve hypoplasia achieved significantly better outcomes than those with cochlear nerve aplasia. And though no single patient characteristic is entirely predictive of outcomes, an evaluation of nurse status and syndrome status could be used as prognostic factors to lead to more individualized care for the treatment of children with bilateral cochlear nerve deficiency. So here are my acknowledgments, and thank you so much.
Our last speaker is Dr. Rajeswaran. I don't know if they're in the audience. No, doesn't seem like it. Okay. Well, we've got lots of time for questions, so let's start by congratulating our presenters, all for staying on time and doing a beautiful job. If anybody wants to come up to the mic with any questions, and do you want to hit it off while people do that?
I'd love to kick things off. I feel like the talks from Dr. Gagnon and Dr. Tonkovich were so complimentary of one another. That was really excellent. I'm curious, you mentioned in trying to address some of these wear time concerns with the patient with high success, you mentioned the coaching and the counseling. For our clinicians out there like myself, is there anything that you find is an especially effective way that kind of gets the message home to those patients who might be struggling with wear time?
I'm always looking for that magic phrase, and I think one thing that I have stolen from UNC is if your eyes are open, your ears are on, if spoken language is your goal at all. And so I think that's helpful. I think what happens is we just have to keep saying it. And sometimes I feel like, oh man, I really feel like I've already gone over this. We talk about it so much in the candidacy process. That's kind of where we begin the discussion about auditory pathway development. And you know, getting the surgery is just the first part. The rest is, it's not going to do any good if you don't wear it. And so sometimes we just have to say that this is not helping if it's not on. But I would love to get any other tidbits or magic advice.
Oh, I wish I had the magic answers too. I have, in the last few years, changed when I'm starting to counsel about the importance of device use, and really started at the first initial appointments for candidacy for the babies, saying that this is going to be a challenge. We know this is going to be hard. Start looking at retention solutions. If you think your child is gonna wear a headband to help keep this on, start putting a headband on them now, and just trying to get on the front end of some of that, and really kind of laying the groundwork that this is going to be a challenge in the early days, and then if it's not, great, but if it is, sometimes I felt like folks were maybe surprised by how hard it would be, and so just that continued counseling through it, but I wish I had a magic answer too.
Excellent. I think there's a question at the back of the room.
So I'm not sure how to get this. Oh, there we go. Okay. So I agree with both of you, and same thing. I start counseling sooner, really. And then the other thing is just telling them, I can see how often you're wearing your implant. And just, I mean, sometimes that, I hate to call it a threat, but just saying, my software tells me how often you're wearing it. So really giving them that idea that this you can't, because back in the old days, parents would say, oh, they wear it all day long, and then now we got data log, and it'd be like 4 hours a day. So just having that as part of it when I start counseling, saying, I'm going to be able to, every time you come in, I'm going to see how often your child is wearing their device. And the eyes open, ears on, I use all the time. I think that's a really powerful. I don't have much beyond that. Also making sure that we're utilizing any kind of help with keeping it on the child's head. Creative ways in which we can do that, fun ways we can do that for some of the kids, having, colorful things or whatever. But I agree with all of you, but just letting them know that I can see how often, and the data logging doesn't lie, so.
Just to add to that, I do think it's a really powerful tool when the parents can see some of that in the app. I think sometimes they think they're doing a good job of keeping it on, and then in the app they're like, oh, that's maybe not as much as I thought. So I do think that's a really powerful tool for them to have their own access to it.
Just to add to that, I also, once kids are a little older and can see the circles or the pie graphs on the computer screen, we actually start to talk about that as far as setting goals for them personally. So, sure, it's up to the parent to make sure that this is happening, but kids can also start to buy into that as well. And I can say, hey, let's set a goal, so see where the circle is now. Next time I see you, I want to see that circle up here. And I am not above resorting to bribery, and that has worked in some cases. It doesn't always work, but just having that buy-in from the child when they're old enough as well, then they have kind of a goal, and they are interested to see what their circle looks like on a follow-up.
I got into a little bit of trouble with that. I promised a patient if her wear time hit a certain point, we would do a dance party, but then the appointment was rescheduled with a different provider who did not agree to the dance party and was expected to participate in the dance party. Sorry, Lisa. But yeah, I appreciate those answers. Over here.
I'm just curious if, Dr. Gagnon, if you have the ability to calculate the HHP in an appointment to share that with the family, because I can see that being used as a counseling tool. I tell families all the time, our goal is to be above X number hours per day, but I don't think that's as meaningful as a percentage of the time they're awake. Sometimes I'm even saying, well, let's think about this. What time do you wake up in the morning? How long do we nap? So I'm almost doing what you guys are using. So is there some kind of like a calculator that we can use to kind of create this and share with the family? Like, I'm so proud that you're at 8 hours a day. However, that only translates to 62% of the time they're awake, so we still have a lot of work to do.
We're really lucky to have a really comprehensive database, and I can put the wear time into our database, and it's going to spit that hearing hours percentage out to me in the appointment. So yes, I have the ability to do that. I'd be happy to, if you wanted to reach out to me though, about how we could get you that calculation more in real time.
Thank you, that's awesome.
Excellent. Over here.
Yeah, I was just going back to the previous question that someone else asked, and I had something to add. As an audiologist LSLS who primarily does early intervention with parents, what I find very daunting for them is the guilt that comes along with this feedback that they're not having their child use their CI full time. So one piece of advice or things that I have started doing more is obviously using the hearing hours percentage is super helpful. And just a plug for Hearing First, I did a great course on there about that. And what really helps for me is what somebody just said about just really just talking to the family. What does your day look like? Figuring out moments within the day, several periods over the day where they could try for half an hour, and really just building their esteem up. So I have found from parents, they report back to me and say, I felt really deflated after I saw the audiologist because my percentage time was way low than what I thought it was. And whether it was the intent of the audiologist or not, they just felt really guilted. So the way that I try to look at it is 2 hours is great, let's do 2.5. Let's do 3, let's do 4, and slowly build up their confidence with being able to do that. So I look forward to sort of exploring the apps a bit more with them so that they can see that real-time feedback.
I think that's great because you're not going to be very productive if parents feel negatively after they leave an appointment. I think they're also surprised if they are using the Cochlear app because it's only looking at time and speech, and then usually our number is actually a little bigger because it's not quite the same as it is in the app. But yeah, I agree. I think we have to celebrate those little victories and have them leave on a positive note instead of a negative one. And I remind them it's an average. So you might have had a really bad week, like maybe your child was sick or maybe they're just not wearing it as consistently on the weekends as they are during the week when they go to school. And so we just talk about this is the average time over the last 60 days. So some of those days are going to be good and some are going to be bad. And I understand that as a parent myself, and even during COVID, like we just were getting through the day. And I wonder if a little bit of that attitude is persisting. But now we're 4 years past that event, and so I think we can build it up again.
In the back?
Yesterday, there was a wonderful presentation on family dynamics and the effect on the CI experience for children. I'm wondering if that's a factor that you've looked at in terms of wear time, if households with one parent might struggle a little bit more with retention. Also, other factors like I think you mentioned whether or not the child is in a preschool, and how the preschool staff understand it, and I think we all ran into this. I'm afraid to touch it. I heard it's expensive. What if it gets lost in the playground? But I'm also thinking about factors like children in a daycare versus in an auditory oral preschool program. I would think that there would be an effect there. So just some ideas for furthering this wonderful research. So thank you.
I agree. Have you looked at that too?
I have not. We've really just tried to start collecting some of that household information, so maybe more to come in the future. We're working on that data collection in this moment. But no, I think those are great ideas as ways to continue the research.
Excellent. I have a question for Jay. You did a beautiful job of looking at that meta-analysis, and the data is so heterogeneous. Did any of the studies, one of the worries I have about putting an implant in children with bilateral aplasia or hypoplasia is it can distract from the development of communication, because people are so focused on trying to get that implant to do something that it cannot physiologically, given the anatomical underpinning. And so it takes time away perhaps from learning good sign. And so did any of the studies comment on the quality or the level of communication achieved by these children? Because I think that's really what we're trying to accomplish with our interventions.
Yeah, that's a great question. So we found that, as I said, about 20% of patients ended up in mainstream school, but the majority of patients remained using sign language at the conclusion of their implant. And the average follow-up time for the study was about 2 years, so maybe with time those audiometric goals change and people are able to develop more communication, but most of the patients remained with sign language following as their primary mode of communication.
Okay. And then I have a question for Heather. In terms of the meningitis component, one thing I wondered about the data was whether or not you had the ability to see any influence in terms of different regional variation in pneumococcal vaccination, right? Because we know a lot of, that's the primary concern. And if not, what are your recommendations to the patients that your clinic sees in terms of pneumococcal vaccination in combination with cochlear implantation?
Yeah, the vaccination question is a really good one. We did try to look at the rates of vaccination and whether or not that influenced the risk of meningitis. However, we found that within this Trinetics database that we used, I don't think that the vaccination data was particularly reliable, meaning that many of the patients were reported as not having had any vaccine at all, when we know that probably the majority of them did receive the vaccine. So our thought is that probably a child might receive their cochlear implant surgery at one institution that reports Trinetics, whereas they might have gotten their vaccines at their local pediatric office, which may not report to Trinetics. So that is something that we would love to look at, but was just not really possible for this particular study, unfortunately.
And do you know what you recommend in the clinic where the research was done?
Yeah, I think we would just recommend the standard CDC guidelines as far as the vaccines, yeah.
Wonderful.
Well, thank you so much to our presenters for this amazing information, and thank you all for joining us. Have a great rest of your day.
I think they want you to go to the podium.
Oh, they want me to go. That's right. Okay, can everybody hear me? Yeah,